We're going for the next speaker, and as you have seen, you see here, Sridhar Venkatapuram is the next speaker. Sridhar is from UK, where he is Associate Professor in Global Health and Philosophy at the King's College in London, specializing in global and public health, ethics and justice. He has an extensive background, degrees from Brown in the US, Harvard in the US, Cambridge universities, and he is working with many international organizations, also in the HIV, in the COVID pandemic. And the title is Academic Global Health and Global Health Issues. The floor is yours.
Thank you very much. So I've just put a timer on, so you might see a bell go off, so I apologize, but I usually...
Well, that's very good, because, yeah, thank you. Thank you for doing that.
Yeah, thanks. So just to tell you that it's not so nobody's calling, it's the timer. So thank you very much. So let me begin by saying thank you to the organizers and to the different organizations that are involved in today. It's both quite a privilege to be able to be associated and participate in commemorating such an incredible human being, but also sort of other people involved. But also it's been a really a kind of selfish opportunity for me to think about an idea and a couple of ideas that this opportunity presents. So it gives me a good reason to think about things and to say things out loud that I haven't thought about before. So the first thing I need to say to you, perhaps if you are from the biomedical sciences, is that I don't have any slides. I know that if you don't have slides and you don't have references, you must not be giving a serious talk. But in my discipline of ethics and philosophy, slides are considered to be a bit too tacky. So the idea is that you are supposed to listen to my words and the concepts that I am saying. And so let's see how this goes in terms of whether you think that I have something to say or you need the references, which I can provide later on. So the story I want to tell is about academic global health and where I think it's been and where I think it's going to need to go in order to be able to point towards or contribute to a more just global health, or more this concept of global health justice. And I want to start with Yup Lang. And I think there's a really interesting story to tell here, which got me thinking and why I chose to accept the invitation in the first place, which is that Professor Lang is known very much for being an advocate for getting access to HIV care, medicine and care to people in poor countries, particularly in African countries. And that simple act of being committed to being sort of committed and making possible access to the kind of newest discovered treatment for HIV to the people in the poorest countries and making it of good quality was a phenomenally important and significant effort and something that is honorable and laudable. And I want to start with that position. I think that it is also true that there's a backstory to this, and I want to start with the backstory because there's some things that really bring us to the present day that are still sort of happening, which is that I was at the 1996 AIDS conference in Vancouver. I was a very young person then. I know I don't look that old, but I am quite old. But so in 1996, I was in my early 20s and I was what you would call an AIDS activist, but I was working at Human Rights Watch. And at the 1996 AIDS conference, there used to be, and I don't know if there still is, there is something called the community forum, which is the non-scientific part where the community members and activists from around the world would spend a few days sort of teaching each other and training each other and working together, et cetera. So for many years at these AIDS conferences, there used to be what we call the community forum. What happened at the 1996 AIDS conference is that there was a split in that community forum, and there was a special meeting organized where only people from the South were able to attend. So when I mean by the South, that is non-rich countries, so non-G7 countries, non-European, et cetera. You had to be from a low and middle-income country to be able to come to the meeting. It just so happens that I have an Indian, or had an Indian passport, and I considered myself from India at that time. And so I was able to attend. The reason why the meeting needed to be organized this way is that the community groups and activists from the South were done and felt as though that they were being dominated by the activists from the North. Yeah? And the idea is that it's not domination in the sense that nobody was holding them to the ground, but their ideas, their issues, their sort of ways of working, the strategies of the activists from the North, usually who were gay men, but also white gay men, and the way that they were addressing issues, what they wanted to address, were not the sort of people from the South said, these are not our issues, not our methodologies, not our agendas. And so we want to have a meeting on our own. And so this is a really important thing for us to understand, that there was an inherent sort of tension and a conflict. And what ended up happening is that the last day of that 1996 conference, there was a press conference where they announced that there was an effective management of HIV through highly active antiretroviral treatment, which is what Yip Long made possible and fought for everybody else. What happened was that in that conference and after that conference, essentially most rich country activists stopped being activists after that conference, yeah? Because they now had access to treatment and drugs. Yeah? And so most now, the South country activists not only had all these issues that they wanted to address, but then they also were like, now we have to also fight for access to this medicine as well. Now, why I'm bringing this up is that it's really important for us to realize that access to medicines in this particular case is one of a long stand of set of issues that need to be addressed and that have been raised from the beginning. So why this comes to why I think it has to do with global health justice is that the story for me continues after that 1996 conference, is that I worked in India, and I was one of the first sort of people and organizations in India to work on HIV/AIDS in the late 1990s. And there was a dramatic shift in 1998 when the Bill and Melinda Gates Foundation set up their first project in the world, but also their first office outside of the US in India. And they committed $100 million to HIV, which was one of the first big things to HIV anywhere in the world, but for them. And that office was opened and directed by a man who was an ex-McKinsey consultant. Right? So he was a director from McKinsey & Co., which I have all respect for management consultants. But the idea is that he was done with consulting businesses and wanted to contribute and wanted to lead the HIV/AIDS fight in India, and so he was directing a $100 million project in India. What also happened since then, and that point, is that HIV/AIDS work in India transformed away from community-based organizing and advocacy to a public health management problem. Yeah? And the reasoning in the way that HIV/AIDS programs were run dramatically shifted. And some of the shifts that happened were most people who worked in HIV programs after that kind of 1998, when $100 million was available, it started to become actually quite cool and lucrative to be part of the HIV/AIDS world, right? So people were interested, one, in their careers, How do I get into a HIV/AIDS work? What is the organization I can go? Where is it going to go? People were interested in making sure that their employer is happy, right? Because the employer needs to also not lose their funding, et cetera. And people were making sure that the government isn't going to get upset, because if the government gets upset, then the employer and they are going to lose their jobs. So this kind of reasoning apparently has a name to it, which is called careerism. And I didn't know this, right? I was like, oh my God, more recently somebody said, oh, that's what careerism is. Why this is important is because that moment in which funding went from little funding to HIV/AIDS community and activist groups suddenly turned into millions of dollars, right? Is that the Ford Foundation's minimum grant was $100,000 at that point. The Gates Foundation minimum grant is $1 million. They don't give you your time unless you talk about more than $1 million. But what's also happened in the world is that in 1990, what is considered to be global health funding was calculated by IHME, which I'll talk about in a second. In 1990, the amount of global health funding was $9 billion. By 2023, that amount has now moved to $64 billion. Yeah? So this is the amount of foreign assistance for health development has gone from 8 to 64 billion. And this is very interesting, right? Because we just had a presentation talking about there's no money, there's nothing, and then we suddenly got a commitment to 100 million, et cetera. So there is a huge amount of money in global health funding in 2023 and 2024. But what's also happening is that it's particular kind of programs and interventions, and what are the kinds of reasoning behind it. But what that also does is shows you how much money is also going into global health academia and what kind of work is also being done. So this organization that calculated that there was 9 billion in 1990 and there's now 86 billion in 2024 comes out of an organization called the Institute of Health Metrics at the University of Washington. The Institute of Health Metrics at University of Washington in itself has received close to $400 to $600 million from the Gates Foundation over the last few years and will do, yeah? And the director of the IMHE has a salary that's larger than the president of the University of Washington and also the football coach. Some of you, if you know the universities in America, if you get paid more than the football coach, that means that you're doing really, really well. Yeah? But so this money in global health academia has affected a lot of things. It has affected how we do your work, what work we do, and how we go about it, and really does affect this idea of, is justice the goal of global health research and global health work, or is something else going on? What happened during the pandemic is an important what I call a revelation, right? And one of the biggest revelations for global health people is that this gold dust that we sometimes spread amongst each other, right? I work in global health, which means that there's this shimmer of gold. You are doing really well, you are serving the poor, you are saving the people from dying, got ripped away. Because we suddenly realized that actually there's huge amounts of problems in global health. There is, with this belief that we are all cooperative, altruistic, and solidaristic, suddenly shows that we're actually not. Most global health organizations are run by people from rich countries, usually white men. And the agendas that they are pursuing are not necessarily the ones that people on the ground want, and they actually undermine it. And when things get really hard, it turns out that they don't advocate for the things that really matter for people. So one of the ways that I was trying to figure out what is going on and how to think about it is that I found a series of psychology experiments on ethics, which I didn't know happens, but I think it's a really sort of interesting, and particularly there's a whole brand of psychology research on ethics, and they called it selfish altruism. And I'll explain it and why it's important and interesting. So the experiment goes like this. So you walk into a lab and they tell you that they're doing one thing, but they're really not. They're actually looking at something else. And they sort of say, okay, we're going to give you 2 dice, like in a card game, 2 dice. And we want you to roll this dice. And we will give you, so don't show us what the dice are, but tell us what the number is, and we will give you the money of the dice, right? So if you roll 2 6s, we'll give you $12. If you roll 5 and a 1, we'll give you 6, right? And so when you did this experiment, you want, according to statistics, the dice will eventually come even, right? So they should all get all different numbers. And so the money also reflected that the dice usually, end up being random but evenly distributed. So then they ran a second experiment, and they said, okay, here's what. We want you to roll the dice and tell us what the number is, and we're going to donate that number to charity. Yeah? And so people rolled the dice, and what do you think happened? Everyone got 12. So one of the things is that there's something about when people think that they're doing a really good thing, their ethics start to get a little bit wavy. Yeah? And so this is funny in that particular situation, but it's not funny when you actually think about our World Health Organizations, global health organizations, global health projects and research. Horrendous things are happening because somebody in their mind thinks, I am saving those people. I am so important that I am, sacrificing other things in order to save this stuff. And then they start doing all these other kinds of really unethical things. And this, I think, is more of the problem that I want us to focus on when we think about global health justice. I have a theory about justice. I'm a philosopher. I can give you a big philosophical theory, read my book. I have lots of things to sell you. But that's not what I think is really important here in this lecture, in this symposium, when it's very much about people and the kind of person that has helped set up these institutions for the symposium, is that this is a problem we have right now in global health, is that this idea that global health is a virtuous, altruistic endeavor is actually hiding and supporting really bad behavior among academic researchers. Yeah? The second thing that's a problem is that interdisciplinarity is dead, right? It's not working. That dream that we said is that we are going to bring interdisciplinary work together. It's stuff. I have found it over and over again that it's incredibly impossible to actually move through an academic career while also being interdisciplinary. Yeah? People say it's right. We say global health has to be interdisciplinary. It's not just a biomedical problem. It's also a social science problem. And I'm here trying to say it's also an ethics problem, right? How many of you have ever actually worked with a philosopher or an ethicist to say justice, equity, what is fair, what is not in these particular kinds of interventions that you do, right? But there's philosophers and ethicists who actually are not really good with working real world problems, but some are. But there's also that part of this as well. So there is something here about global health still being very much we are trying to figure out how to do it, but still very much a biomedical problem. And the third thing I would say is that global health, at least in the US and in the UK, and I'm not going to speak about places that I don't know about, is that global health institutions and institutes and academics are all about research. We're going to do research, we're going to solve this problem. And standing on the other side of funding research now for over 10 years, where I've sat on selection committees, to actually say, what have you actually produced out of the research, the millions that we have given you, that has actually improved the lives of people in poor countries, whose name you used to actually get the grant in the first place? Right? What is actually the impact and the outcomes, as opposed to how many promotions have you gotten as a result of these grants? This is a problem, and this is a problem that people from the South know exists because they see it. So I want to go back to that 1996 meeting where people from the South sat in a room and we talked about what the issues were and what the problems are. So I want to tell you that that's also happening now with global health. So as we talk here about what should global health justice look like, I want to say that there is another room somewhere where people from low and middle income countries are talking about what it is that's important to them, what are the different kinds of issues. And what I'm trying to do is at least tell you that there is something wrong here that's very profoundly wrong. And global health, for it to be just, we need to start acknowledging some of the really important things. One is the poor ethics of global health researchers and program administrators, et cetera, when they sort of are actually doing things that we would consider to be unethical, but because it's global health, they get a free pass. Two, the idea of this problem is not a biomedical problem with a biomedical intervention. It's not a, I need $100 million to solve Mpox. We know that that's not going to work. Right? So that is the problem. There you go. And the third thing is this sort of, how do we think about impact? I mean, one of the things reason I came to this talk is that, you guys have been really focused on, we do things on the ground, we deliver. We're not just sort of doing publications, and that's really important to me. So I hope you take away from this in a very friendly way, right? I'm not here to do anything but to talk about justice, but justice requires starting at home, and these three things are there. If you want to read about philosophical approaches to justice, I'm happy to sell you my work and my books, right? Thank you very much for this opportunity.
Thank you very much. That was a nice presentation, and I hope that people will react on that, because yes, you are. Go ahead. Well, I have to. Can you over there?
I'll run slowly.
You run slowly. Okay. Go ahead.
Thanks for the talk, also for kind of provoking this process of discussion of what does it mean to do research in global health. I want to go a bit, you created this dichotomy between global north and global south and this kind of thing. But I would say that within the global south, also within these countries, there are so much of hierarchies over there that we could not just put them together in one category and say this happens. Partly because of Bill and Gates Foundation created this whole elephant of a hierarchy in India, that now they become like the Public Health Foundation of India and all these different groups, that they become the new elite, which we have to also fight with when we are doing field work over there. How do you see this in that context?
Yeah, I mean, I think that you're right. There's lots of on-the-ground dynamics, and there is now a whole social and hierarchical infrastructure around public health in low and middle income countries. No matter what country you go to now, you'll be able to find some sort of nascent social hierarchy of public health, right? Because it's no longer the geeks who are worried about cholera and infectious diseases. Now you have people with Harvard and Johns Hopkins degrees who are working in their sort of project on blah, blah, blah. And then they're all sort of finding out. So I think my thing depends on who you are and what you want to do, right? So my thing is now very much the future is all about the local. The future is all about the regional and the national, right? And so it's very much about how do you build networks and colleagues and sort of systems that will guide you towards equity and justice that you all agree to. Not what equity and justice that the funder or Bill and Melinda Gates or WHO or whatever has decided that's what it's going to be. So that would be my focus on it.
Okay. Constance? Yeah, sorry. Yeah, it's coming.
Thank you very much. A very nice and provoking presentation. I just want to follow up on what you just now, and my question is actually about what you just said, because we are sort of, not just academia, but all of us in working in global health, determined by the funders, totally. And And it's individuals, literally, at the funders who decide what is interesting, what is not interesting, where money should go. So that is an angle that is pretty determining where we go. What is your view on that?
So I had a section on funders, and I skipped it because I didn't have time. So thank you for giving me this opportunity to talk about that. So a couple of things. The UK has sort of the government funders. It also has a very specific global health funding stream called the National Institute of Health Research Global Stuff. What's fascinating about it is that I kept looking at it, is that they do not support any research that looks at transnational organizations or processes. They only look at subnational interventions. Yeah? Which means that to them, the global health problem is, in that poor country, what is that problem and what is the intervention? Not what is wrong with the global architecture that's actually creating all these problems in these countries. And they're not going to fund that, right? And the Wellcome Trust in the UK, I've worked with sort of on their panels for a long time, for many years. And, as I was saying to you earlier, is that the Wellcome Trust is now one of the largest foundation philanthropic organizations. It has to give away £5 billion in the next 5 years. Yeah, it's desperate to give away the money. It's not a problem. I mean, like, if you think you are desperate to get money, there's the other problem on the other side, which is we're desperate to give money away and desperate for quality applications, right? But what's interesting is that there's been a lot of problems at the Wellcome Trust because they thought that they were really cool, and they did are we a racist organization evaluation. Guess what happened? Yeah. Yes, you are. And then they're like, oh, we have failed in sort of living up to our, sort of stuff. But then they came out with an interesting statement. They said, we are not a social justice organization. We are a scientific research organization. Yeah. So I hear you when you say funders are not stuff. But what I know is that you are not a random researcher in this ecosystem. You're actually quite significant and quite powerful. So if you had actually a conversation with whoever the funder is and say, I'd like to talk to you, we think that there is a problem here, they would at least give you time for a cup of coffee. Right? And that's the thing that I think we need to start thinking about, is that, we are not powerless players. If we've done any good work and if we've done that stuff, then we actually can influence the way that the funders affect and choose their agendas or do things differently. And I would explore those kinds of things.
Okay. One other question is, a lot of institutes before had the name of Tropical Health Institutes, and now they call themselves Global Health Institutes. You think they still have a role? Or for how long? So I know the history of so this whole thing comes from colonial medicine. Exactly.
Okay? No one is hiding this. And no one needs to hide this, right? So this we're going to do this sort of medicine to protect our colonizer population, right? To prevent them from tropical diseases, fine. That's what was there, and that's what happened. And then it became international health because we were talking about stuff. And what annoys me, right, and this is stuff, is that people use the term global health when they actually want to say poor country health problems.
Exactly.
So for me, global health is that, but it's also, well, what's happening in the EU with the sort of transnational health issues? What's happening with the global architecture and processes and stuff like that? So to me, if you use global health and say, oh, well, what I mean is my intervention in that low and middle income country, and somebody else is saying, no, I'm talking about how the global architecture of finance is affecting health, I don't think that you should be telling me that that's not global health, right? And I'm not telling you that that's not global health. But it's when people use it in a very narrow way that I think the problems start. I do think that global health, there's no words that will always stay fixed in time and space about their meaning. There never has been. Freedom, equality, justice, right? These words have not always stayed the same. So we need to be a little bit more flexible about global health. What does it mean now, and what should it mean 10 years from now? We'll see.
We'll see.